All right, so let's start. Good evening from Germany. Welcome to our maintrac online forum, the second of 4 sessions in 2025. My name is Svenja Frister and I work as a physician at maintrac stemtrac. I will be your moderator for today's presentation. The topic is personalized therapy monitoring in colorectal cancer patients, how maintrac and stemtrac can provide support, presented by Professor Dr. Pachmann, founder and CEO of maintrac and stemtrac.
So today I would like to inform you about how maintrac and stemtrac can provide support for personalized therapy monitoring in colorectal cancer patients. The colorectal cancer is an increasing disease. New cases in 2022 were almost 2 million, with 1 million deaths in 22. By 2030, about more than 2.2 million cases are expected to occur, with 1.1 million deaths. The cases are rising in younger people, and in Europe, there's a concerning rise in colorectal cancer incidence among people aged 25 to 49. In England, there has been an annual increase of 3.6% in this age group over the last decade. And experts highlight the risk factors for such an increase, such as unhealthy diets, obesity, and lack of physical activity. However, death in colorectal cancer is mainly due to metastasis formation. Metastases are formed by tumor cells that can detach from the primary tumor or from already existing micrometastases and enter the bloodstream, and they are called circulating tumor cells. In the bloodstream, they can survive, settle in other locations, and start growing again, forming metastases. It's believed that metastases mainly originate from circulating cancer stem cells. And I will go further into that later. So maintrac can be subsumed under liquid biopsy. It's a minimally invasive procedure that allows detection of living circulating tumor cells. What can we do with the maintrac liquid biopsy? We can count the cells over time repeatedly and see how these numbers develop. Therapeutic substances can be tested on these currently present tumor cells in the patient's blood. Therapy-relevant tumor characteristics can be determined, but this is less important on colorectal cancer cells because there are no therapy-relevant surface characteristics. There are mutations, and I will go into that also later. And the aggressiveness of the tumor can be determined by cultivating with stemtrac so-called tumor spheres, clonal expansions of cells that are able to grow. How do we determine the colorectal or the epithelial tumor cells in blood? There is an antibody, again, with this fluorochrome labeled against a surface antigen, which is typical for epithelial cells, EpCAM. And thus we can see among the white bloods the circulating epithelial tumor cells. It can be used for all cell tumors. It's fast and reproducible, and it's performed in a thin ISO 15189 certified laboratory. So how do we proceed? We get the blood from you and we perform as a single enrichment step lysis of red blood cells. And after red blood cell lysis and centrifugation, there is a tiny sediment in the sample, and the cells from this sample can be labeled with green fluorescent anti-EpCAM antibody, and the suspension is then transferred in a 96 well plate, and we have a special microscope that identifies the green fluorescing cells for us then we can draw a trajectory of cell numbers over time. How do we detect these cells? On the right panel, there are living cells. They should have a nice visible nucleus. They can be stained differently in only caps or the whole cell. Then in the middle gallery is cells that are not really determined as living because they often have green fluorescence. We cannot find nucleus, and these cells are not counted under usual conditions. And then there are on the left panel the cells that are truly dead cells, where we can see a red stained nucleus due to a fluorescent dye that can enter the cell upon permeabilization of the membrane, which occurs in dying cells and can then intercalate with the DNA in the nucleus. These cells are also emitted and counting living cells, but they are important if we determine cell death upon cytotoxic treatment. How we display the results is shown here. We display them as the number in 1 ml, and it can be calculated for 5-liter blood as a whole. And the results are given as 50, which is a minimum number, and then minimal to slightly elevated numbers, and so on. So we also give an estimation whether there are many or few cells present. How can we use maintrac? We can use it in first place during or after therapy monitoring. This makes it possible to monitor the therapy and directly observe tumor activity. In addition, it provides a tool for optimized and personalized therapy. We have analyzed the data for non-metastatic primary colon cancer and analyzed 77 patients with those with decreasing cell numbers or stable cell numbers having significantly fewer events. Only 1 out of 52 patients with decreasing cell numbers had relapse, as compared to those with increasing cell numbers, which had much more relapses during this time. And the median time to 50 events was less than 1 year. And this is shown here as a Kaplan-Meier plot, where the patients with decreasing or stable cell numbers shown in the green line, those with increasing cell numbers in the red line, and each tick down is a relapse. And you can see that the patients with increasing cell numbers have a much higher probability to relapse. Under chemotherapy, where we have less data, but there it's even better, the results. Those with decreasing cell numbers have significantly fewer recurrences, none out of 15 patients, compared to those with increasing cell counts, where all of the patients suffered relapse. And this is shown down here in this table. And indeed, the time to median relapse was again the same, less than 1 year. And this is the Kaplan-Meier plot, where you can see that all patients with decreasing cell numbers, the green line, remain in complete remission, whereas during the next 2.5 years, almost all patients with increasing cell numbers during chemotherapy have suffered relapse. And these are 2 examples. One patient who was a 42-year-old woman diagnosed with colon cancer, relatively large PT3 with involved lymph nodes, but a low G2. She received surgery in May 2023, and then adjuvant chemotherapy with FOLFOX and panitumumab, and subsequently she only had therapy with panitumumab, and she had decreasing cell numbers. Now in the end, she has an increase. We don't know what this means, but currently she is in consistent clinical remission. The other patient was a 47-year-old woman with also a quite large tumor, more involved lymph nodes. She received surgery in April 23, and then chemotherapy with Folfox. And after the end of Folfox, first she had a reduced number, but then re-increased. Currently, there is no sign of recurrence, but we think that this patient needs to remain under close surveillance. Do you have any questions at the moment?
Yes, 2 questions I have. The first one, have you published the results yet?
We haven't published the results yet, but we are still already in preparing the results for publication.
And the second question, what happens if tumor cells are still detectable in the blood despite therapy?
Our experience is that there are almost always, after the end of therapy, cells detectable in blood, but these cells can be dormant cells. And that's why we need to monitor these patients, because if they are dormant cells, they will remain at the same level or even decrease over time. But if there is a re-increase, this is an indication that there is, again, tumor activity, and then these patients should be monitored. And if we find more than twofold increase, then we sometimes suggest doing imaging on these patients.
One question here, can circulating tumor cells be detected earlier than imaging techniques?
Yes, they are detected, as I said. The relapse, which we showed in the Kaplan-Meier plots, that's detected by imaging, and we detect these cells, the increase, about half a year to 2 years before imaging can detect the relapse.
Does the time of collection, so evening or morning, has any significance?
We have not seen any significance. There is reports on that tumor activity is more often observed in certain times of the day, but we cannot see a time-dependent number of cells.
All right, then thank you very much. We would go on, please.
Okay. As I mentioned, there are different treatments, and in the beginning, the patient doesn't know whether the drugs which are prescribed will be effective on his personal cells. And this we can also test in the maintrac testing. We can demonstrate whether the cells actually in blood respond or do not respond to the individual patient to cytotoxic substances. And the substances can also be tested in various concentrations, combinations, and even under hyperthermic conditions. So that's what we see here in each of these panels. It's one individual cell which has been observed and monitored over time. And you can see the cell in the control without any addition of cytotoxic substances will remain alive even during this 9 hours period. In substance 1, there is a very rapid decay of the cell with a red fluorescing nucleus, which means that this cell has very early been the membrane permeabilized, and the dye can enter and show the dying cell. And this is different with substance 2 and 3, and it's dependent on the time, how fast these substances lead to cell killing. We display these results according to this panel here and express it as the percentage of dead circulating tumor cells among the present cells. And if it's less than 10% dying cells, this would mean that the drug is quite ineffective. Between 10 to 50% dying cells is marginal, and more than 50%, we would call it an effective response, typically consistent with imaging. Where can we apply such sensitivity testing? Most preferable, it would be after the initial diagnosis of the primary tumor, before the therapy is initiated, already test the planned substances. And here it's shown that the two most effective substances should be used. In the metastatic setting, prior to starting a new line of therapy, it could be helpful to test the sensitivity. And in cases of disease progression during an ongoing treatment, it would also be helpful to see whether the used substances are still active. Here, I'll show you a Kaplan-Meier plot on the metastatic colon cancer. And again, we analyzed 92 patients, and those with decreasing cell counts had still, even in the metastatic situation, significantly fewer recurrences, 10 out of 41, compared to those with increasing cell counts, which were 44 of 51 patients. So the patients with decreasing cell counts in the metastatic situation had a significantly longer event-free survival. And this is shown in this Kaplan-Meier plot, where the patients with increasing cell numbers, the red line, had rather early their relapses, whereas in the patients with stable or decreasing cell numbers, it took up to 6 years to get to the 50% relapse rate. And this is a case report on a metastatic colon cancer. This was a 59-year-old woman diagnosed with metastatic colon cancer, and the primary tumor was subsequently removed by surgery, and then an individualized chemotherapy protocol in combination with radiotherapy. And this resulted, as you can see, to a complete elimination of the circulating tumor cells, consistent with complete radiological remission of the liver metastasis. And indeed, this was the oxaliplatin and the irinotecan were both very effective. And this is another case report of a metastatic colon cancer. And again, this patient was treated with Lonsurf. It did not reach the threshold of detection, but it resulted in a decrease of circulating tumor cells consistent with a positive response to therapy. So, do you have questions?
Yes, some questions have reached me. The first question, which substances can be tested?
Well, we can test conventional cytotoxic substances as well as natural compounds, but we can only test the cytotoxic effect of these substances. So if there may be substances which lead to slowing down the growth of the cells, but we can only test the cytotoxic effect, because cells must be lysed to be shown to die.
All right. What is the maximum time dying cells can be observed? What is normal?
It depends what you call dying cells. Is it during therapy or during the in vitro analysis? During the in vitro analysis, mainly most cells that are prone to die during these 9 hours that we observe the cells. In vivo, after therapy, cell death can occur days and weeks after the treatment. Our test looks only for those cells that die immediately after the addition of the substance.
Do the circulating tumor cells in colon cancer differ from other types of cancer?
There are no specific surface antigens which we know are available to characterize the colon cancer cells, but there are typical mutations inside the cells, like KRAS, and I will show later typical example how we can test these cells, but it's a cumbersome approach which we would not recommend for routine analysis.
One last question for this round. Does performing a liquid biopsy at the time of a tissue biopsy have any correlation with the overall survival, potentially due to metastatic risk caused by tumor cell dissemination from the biopsy procedure itself?
Well, biopsy procedure we didn't analyze, but what we have done is surgery, and surgery can release cells, and we have shown not for colon cancer, but for breast cancer, that these cells, if they remain and increase in number in the circulation, that's indeed an indication of relapse looming in the next time. But we can also see colon cancer patients who have increased numbers after surgery, and we need further analyze these results, and I think we will get the same results or even faster relapse if cells are released and can grow in blood.
And has liquid biopsy a higher risk of releasing tumor cells into the blood?
Liquid biopsy usually is taking blood and looking for mutated DNA or cells as we do it. And this does not carry any risk because it's far from the tumor and it's just a sample of blood withdrawn. And we have no information that this simple blood withdrawal would lead to increased risk.
Right, thank you very much. And please proceed.